At the onset, let me thank AOP Ahmedabad for this invitation. Also thank Dr. Subramaniam to keep you awake in post-lunch session. Believe me, it's going to be difficult to walk in his shoes, but we will be working on the similar lines. The uses of X-ray, which is restricted to neonatology. So let me start with the case scenario straight away. That this is about a 27-year-old Paimi, absolutely uncomplicated pregnancy. Of course, this was IVF pregnancy, and both the parents are quite literate and coming from the same profession that we are in. And elective LSCS as full term for severe PH in mother. Mother is radiologist. Grunting and oxygen requirement. Murat joyudu પણ છતાં baby મુરત નહોતું જોયું. So baby started with full grunting and oxygen requirement. And as usual, it was something like 10 liters per minute in oxygen requirement in labor room. So straight away baby was shifted to NICU and we started with high flow nasal cannula oxygen. At 6-hour age for worsening distress, look at this baby, there's elective LSCS from a quite a established family and with Murat, but within 6 hours, baby getting into trouble and which is not obviously digested to parents. So first they'll ask you that am I doing right thing or not? Is that my ventilators are not having any baby on? So is this the reason? So obviously there is reason to ask you questions and we are happy with that. So the first question was asked to me was that what is blood gas? Because for any non-neonatology person, they look at the respiratory failures, increased CO2 and hypoxia. But they are not tuned to, and then look at the x-rays and blood gases, but they are not tuned to look at the kind of distress that baby is having. 6 hours, 10 liter oxygen with high flow and baby failing. So Dr. Ravi, you are there on call on that day. And now I know the background, I give the background. What is your idea on this one?
Obviously, it's a full-term baby, so we have to go on that line because the differential diagnosis on full-term and preterm babies are different. So first thing I will ask was there a history of meconium? Probably not because it was clear like a.
Okay.
So, okay. બધું નીકળી શકે, yes. So, see, if we go from the smaller diagnosis to higher, but it looks like higher, but first we will be always transient tachypnea of newborn, though the requirements are quite high on that side, but sometimes it can happen. As I told, meconium aspiration is not there. Then we have to think of congenital pneumonia as well. Then, so these are the respiratory findings. Then the other congenital abnormalities like now we know that the ultrasound is done very nicely, but diaphragmatic hernia should be on the case as well. Cystic adenoid malformation should be
so
there.
Everything under sun which can come to the lungs,
because it's a full term
that is coming to your mind in spite of knowing that mother is radiologist.
Yeah. Anything we have to think of when we are dealing with, and as sometimes if there is a history of diabetes or something, and if the steroids are not given, sometimes in elective section we get RDS in full term as well. So between 1 to 5% that can happen as well. So that also we need to keep in mind. And lastly, undiagnosed PPHN due to any other and cardiac causes. So
okay.
but that's how it should come in.
So that means we need more investigation to come to the conclusion. But as far as management is concerned, it remains the same. You intubate, stabilize the baby. Now Parag was called because he was close to the mother, and then he was said that what is X-ray like, and go and review the X-ray. The Parag did this X-ray, and this was the X-ray. I'm pretty sure Dr. Subramaniam will accept that this is a good position and otherwise well exposed X-ray. Am I right, sir? Okay. Okay. So Parag, your views on this with the background history, which are the possibilities here?
Well, with this X-ray, actually only left lower zone seems to be, I mean, retrocardiac, there might be some shadows which we might take with a lateral X-ray. Otherwise, the X-ray looks fine. This was not intubated, right? I mean, this was before intubation.
Yeah, this was before intubation.
This is just feeding tube, not a tube actually. So, now a feeding tube.
No, it is before intubation. Yeah.
Okay.
So if you look at this,
there's just some
quite well expanded, good lung volume, and quite a reasonable good air around. So then, what will you advise to me, Dr. Mehta, what I'm supposed to do now? Because parents, high-fi families. I'm at the receiving end, intubating their baby at 6 hours of age. મને કંઈ કહેતો ખરે સાહેબ કંઈ કરો આમાં કે which are the possibilities I want to convey.
Well, one is of course pneumonia on left side, which could be there. Even left middle zone also looks bit like you can see air bronchograms. So that is one possibility. But would that give rise to this much bad condition? That it doesn't explain actually.
Absolutely. So this is the first X-ray of the life of this baby, and within 6 or maybe 8 hours by this, maybe 6 hours I'll say. And looking to me, it was looking pretty normal. Obviously, with the background history of such a high oxygen requirement, I'll not take this normal. But that means that this X-ray is not going to tell me what is the problem, isn't it? So then Manish came in the round and he said that antibiotic chalu kari nat kari. So will you start antibiotics on this or not, Manish? And
Yes,
if
actually,
then which antibiotics?
to start
Because basic
with,
math is done, baby stabilized now, gas is
Yeah.
normal, X-ray has been done, you
we-
take culture.
we should take blood culture first and then start the antibiotic according to unit protocol, and it's empirical initially, but keep in mind that if the bug is or pathogen is identified, then we always it's change the antibiotic choice. But yes,
in all,
starting
we
antibiotic,
agree
yes.
that there is no congenital malformation sitting here. It is a pretty good lung on X-ray, but having unexplained oxygen requirement, unexplained distress up to this stage. And then we started on antibiotics after blood culture. Day 3 means 40 hours, 48 hours into the life. Ventilator parameters are not improving. By this time, echo is been done. Obviously, secondary elevated pulmonary pressure. That is what they will say. It is a transition of the circulation that all those are sitting here. They know that. But the question to a medical professional would be that what is happening to my baby? Tell me, doctor, where the things are wrong. She is a normal pregnancy, elective CS, everything is fine. And believe me, at that stage, I never had a clue what is happening. So after 40 years, repeat X-ray is done, and this is the X-ray, and this is a tube 1. And Dr. Sunil, you are now there. So what will you? Because Parag said that previous X-ray was not that bad, having some haziness here and there, and now on high parameters, third day of life, X-ray is behaving something like this.
Sir, with the current information available, there is a chance that they are from an educated family, and all the screenings must have been done. So less likely that the mother had any event during her course of pregnancy or any maternal infection. We don't have any reports on that. So congenital pneumonia is a possibility, but in this case, the information available, I would say it's a early onset sepsis. But also the baby has a LSCS delivery, so there is no prolonged labor or chorioamnitis or any other history. So with that, I think they are EOS and congenital pneumonia are maybe clinically they'll have anyways have the same presentation.
In short, as usual, suspected sepsis, subsetted pneumonia, you are struggling with the diagnosis. So can this be a congenital pneumonia? Can this be, how will you label this? This is a early onset, late onset, or this is congenital?
So the X-ray has deteriorated over 6 hours, and the condition is also deteriorated over 6 hours. So maybe early onset sepsis, it goes more in that direction.
Okay. So
Congenital.
will you put as sepsis, or because so far baby otherwise is fine? So,
At birth, the baby only had grunting, which could be due to secretions or could be just a normal phenomena. But the child has deteriorated over the next few hours, so I would consider EOS.
what do you think, Dr. Parag?
What are the CBC, CRP, and those
As
primary
usual, we know
findings?
that's normal at first. CRP we don't ask at 0 hours or maybe
48
24 hours.
I mean,
48 hours this morning, first test is done. So far we are awaited, the results are awaited. Baby has behaved well, baby is on full feeding, tolerating well, and not
Perfusion
showing any
is-
signs of systemic infection.
Perfusion is fine, sugars are fine.
Absolutely.
Foods
Baby is
are
absolutely
tolerated.
fine.
So
See, the doctor, both our parents are doctor, they would know if I am saying congenital pneumonia, how it is possible. Mother is absolutely fine. Mother doesn't have fever. There is no signs of weak contractions or premature contractions sort of thing. And at the same time, there is no fever, no UTI, no cough, cold. So shall I blame is a congenital pneumonia? If yes, then why? Then it is fitting into that.
it is
history
fitting
not
more
fitting
into
here.
congenital pneumonia.
If I say early onset, which normally happens within first week of life. So the diagnosis to the audience, the dear colleague, the
Be-
problem here is the diagnosis. As per the management is concerned, probably it will not a huge difference. But shall I label this for the practical purpose in a discharge summary as a congenital pneumonia, or how shall I explain that number the word? Congenital pneumonia has to come from the mother during perinatal period, where early onset pneumonia will come little later as a transition, is a
Transition,
transferred
yeah, after
from the mother
during the process of
during
delivery,
process
the
of
child will
delivery,
get
or
acquired
immediately
infection.
within first 2 days. So again, the dilemma remains same, and as we are in the pneumonia conclave, we restrict to that discussion rather than going to sepsis part. X-ray is not helping me at all. So the question is that why babies are risk for the congenital pneumonias. Believe me, when I look at the literature, if you look at the infection part, systemic infection, all reasons of the system, at least 40% systemic infection because of the pneumonia, 30% are because of UTI, and rest because of something osteomyelitis or meningitis and all that. So that means 40% pneumonias are responsible for systemic infection. That means margi gelu ke indu pelu. Pneumonia causing systemic infection or systemic infection causing pneumonia. I am sure that as far as management is concerned, doesn't matter. But those who are want to think logically, it's really impossible to pinpoint which came first.
So maybe it is something like mother's silent infection, somewhat like CMV or chlamydia.
We are
or-
coming to that. We are coming to that. Yep, that's good thinking. Absolutely. But as I told you that doctor છે તો diagnosis માગે છે અહીંયા અને હું કહું છું કે મારી પાસે diagnosis નથી. So it's another important part of how to counsel them. Be truthful. I said that I do not have any clue to this problem. When obviously there are so many friends in the community of him. We'll discuss it out. But I just put my foot down. I do not know the diagnosis of this baby. As far as management is concerned, at this stage, it won't differ. Stabilize, antibiotic, and wait for the lung to improve, or give me some clue by which I can work on the baby. That's fine. So we all know about this part, why babies are, my babies even full term or preterm, they have poor defense, innate immunity, adaptive immunity, IgG is less, positive alveolar macrophages. This is most important, why they are prone to pneumonia. 40% systemic infection coming from the pneumonia, and this because of the macrophages are not working appropriately in the lung. Neutrophil dysfunction and lower level of many complement component lack specific antibodies. So that's fine. And now West Parag says that it is a maternal infection during pregnancy, but our obstetrically would have screened the mother, and mother surface radiologist, father is the physician, so they would know that what screening, which kind of screening is required from the maternal side. So that has been done. That's fine. So doctor, here can you, as one of you can, what are the risk factors for early onset pneumonia? Which are the risk factors?
So it is more common in prematurity because sometimes there is a leaking as well. So prolonged rupture of membrane, premature rupture of membrane, maternal fever, maternal chorioamnitis. And not to mention, we are always taught in neonatology that girls has better outcomes, so male are a little bit more common as well. And lastly, I'm not blaming, but repeated vaginal examinations and instruments during delivery, those all things.
Yeah, but this was a case where the elective CS, so
CS,
vaginal
yes.
examination was not done.
Previously
This was
also
not a premature. This was baby girl, good size. Yes, GBS sepsis, I don't know, it is not seen in this part of the world, but now we have started seeing few, maybe 1 in 2 years. Mothers are colonized with group B strep. Normally in Asian countries, they are colonized gram-negative organism, but somehow things are changing. Baby crashing at birth in Western countries has to be group B
strep.
screen. And antenatally also all mothers are screened. Urine is sent for the GBS antigen. So this was not the case, that is not the pattern of the protocol over here. So that was not done. That is acceptable. But having said that, even if it is GBS sepsis, they all behave like this, but treatment will be penicillin group of drug, which was already started by Manish. So that has been covered. Here, after starting, still this baby was in trouble, and we had never any clue what is happening here. Yes, inborn metabolism galactosemia, but we know that galactosemia will not never come in the labor room. It will come later because they are prone to
E. coli.
gram-negative infection that we all know.
E. coli sepsis and things.
chorioamnitis, yes, this can be, which at this stage we are not aware. Someone can argue that why you are talking about chorioamnitis, because has to have some fever, has to have some high WBC count. But I will refer Dr. Pauline again and again. He has very good study almost 16 years back now. Good number of placenta are having histopathological changes but no clinical presentation. So those baby that we are seeing unexplainably going into the respiratory distress, they can have chorioamnitis, but then what does it mean? That every patient need to go for histopathology. And then you say that it is normal, that baby is fine and there is no coronavirus, which is not possible. This study was given was a community study, and they found that good number of, it's a 38%, somewhere I don't remember the exact number also, but placentas are the one which are the source of infection in good number of TTN that we diagnose and treat. Because TTN also we give antibiotic, we never do that, we declare culture, give antibiotic. Those are the non-bacterial infection maybe, which we don't know. Anyway, so which are the pathogens of congenital pneumonia, Manish?
Yes, different pathogens are different than the routine bugs. Like for congenital pneumonia, we suspect toxoplasma, herpes simplex, cytomegalo, and Treponema pallidum. So these are the congenital pneumonia causing organisms.
Yeah, but most of them will be going for the babies, for the mothers who are compromised, sexually active mothers and all those, this Treponema pallidum and herpes and all this will come from there. This was not possible for this family. So still there is no clue what is happening with this. And what about pathogen, early onset pneumonia, Parag?
These will be generally from maternal flora or the surfaces where the baby is being delivered or the instruments which are being used. So this will be commonly like Streptococcus, E. coli, the common ones which are in the mother's vagina and UTI if at all she has. Then Listeria, Staph, Haemophilus group. GBS can also again be one of them. And coagulous negative staph. I think these are the common organisms for early onset staph. They will be generally sensitive to the regular antibiotics.
Is it important to find out this bug at this stage on this baby particularly? Does it matter the management, because you're going to call it antibiotic and you're not going to start antivirals or antifungals on third or fourth or fifth day of life in this baby?
But at least blood culture is mandatory.
Yeah, it was done so far. You are right. Anytime antibiotic, we are told that it is to be given, and we started that. That's
and
fine.
if at all the child is intubated at 6th hour of life, I might consider tracheal aspirate. If at all I am getting some bad aspirates, I would consider at early stage, not
so
after
what I
1
want
or
to
2
convey
days.
that finding out organism, yes, look good in the book, and as I keep on telling with each session, that places where the books are written, not the places that we work. We never ever see this list of gram positive. If at all you get one is gram negative, and then other atypical ones difficult to culture and difficult to get one. For me and you, the problem would be that which bug is then which is causing these shadows and ventilator dependency, where the heart is normal now. By this time 2 echoes are done, heart is normal, lungs are in trouble, no other malformations are seen, and the blood cultures and everything is not helping me out. So is this a non-bacterial sepsis, which can be non-bacterial pneumonias, which is possible with the, but since we are talking about early, we can discuss the late also, and you can see the all sorts of problems are there. All sorts of organisms are there to list it. But how many times we get one which will help the management? Never. And that brings the fact that only one on the late onset, they are worried is ventilator associated pneumonias. Good number of pneumonias in the places where we work, NICUs and all the PICUs, are related to ventilator associated pneumonias, and that is where we are stuck with. So Parag, let's get away from this case for a little while. Can you tell me about the CDC guideline to label pneumonia? Parag or Sunil? Yeah.
So specifically, if we are looking for VAP, so it is defined that a baby
Not web,
who's
this is talking about in general diagnosis neonatal pneumonia.
Okay.
What is guideline?
radiographical changes and then supportive blood reports which might show as per infection which parameters are altered. Otherwise, distress will help us in thickening of altered blood gases, thickening of secretions, and all those reports we can.
So in short, we have got three group where we are supposed to get one out of that. CDC guidelines said new or progressive infiltrates. Because this baby never had typical cardiac or congenital problems, only one from this group will be suffice. So new or progressive infiltrates were there. Baby had dependent changes on different changes on the axis depending on the kind of axis that we see. On gases, worsening gas axis or any of the following, increased oxygen requirement was already there. Increased ventilator demand was there. And then one stage we are thinking that we should get on the high frequency or not. And then you got this leukopenia, band forms, apnea, nasal flaring was there, wheezing were not there. But these are three, at least one out of these three will tell me it's a neonatal pneumonia. It fits into that. So my diagnosis on neonatal pneumonia, only thing is that I could not get the bug or where I am wrong, or what the pathogen is and why baby is not getting better.
To be honest,
So,
sir,
yeah.
we never diagnose neonatal pneumonia. We diagnose whether the baby is septic or not and whether the baby's respiratory functions are altered or not.
Perfect.
If they are altered, they are supported. If the infection is there, we treat infection.
That's what the important is, that in a pediatric or adolescent population, pneumonia, patches, chronic constipation does matter. In newborn, first of all, if you look at the X-rays, always difficult to get proper position because lines and nautical tubes and difficult to hold the babies and inspiratory and expiratory that look good in the book. Practically, at times you feel that why don't you get another film or will repeat after 2 days or something like that, and you can't compare one with other. So as far as diagnosed pneumonia is concerned, probably X-ray is old one or old technique, I'll say. Anyway, differential diagnosis, we all know that. And then we talk about atypical pneumonia, Ravi or Parag. What you can this a chlamydia? This patient, can this was a chlamydia pneumonia?
Anything could be possible because see now you have managed the baby is stable. So now if gradually baby is improving, whatever it comes out, now we are out of corona area as well. Otherwise, coronavirus
Absolutely,
is also
great, perfect.
that was the first diagnosis once the bacterial was not there before 2-3 years as well. So yes, it can be chlamydia, urea plasma, listeria, anything atypical, mycoplasma, anything could be there. But
Yeah.
that will be very difficult to find out unless we get a proper history from mother.
So when you talk about urea plasma, will you consider this bug in a full-term babies?
No,
And when?
less likely in full term, especially in chronic lung disease babies and with lot of handling, those bugs are present.
And I'm sure that the drug that I'm giving right now, maybe piperacillin and tazobactam, that is what I'm offering with one aminoglycoside to this baby. Will this work on this organism, or either of that? So either this chlamydia or it is urea plasma. Will it work on that? So that means a clinician, I'm still scratching my head that can this be these two or not?
Sir,
Can this be one of these
actually-
also?
Chlamydia would be more common in a later age, somewhere around 1 month or so. They typically have that staccato cough, cough with each breath.
Absolutely.
And with that, they'll have some counts, other things correlating with that, and then you consider about chlamydia.
So now this is almost 2 or 2.5 weeks into that. Baby has got off and on, coming off ventilator, coming to high flow nasal cannula, getting back on the ventilator. And dilemma continues, pressure on the treating doctor continues, reports are reviewed again, one authority, other authority, but none of them could commit that where the problem is. And no one would like to take this, I'll say the share the responsibility. So that Dr. Mehta is best, don't worry, he will do best. And Dr. Mehta only knows that where the problem is. Anyway, so how to diagnose this? Ravi, what about laboratory tests, whether any of this can help me or not?
Yeah, definitely it will help. Plus, now that was my another question. Now we have to go ahead with other investigation because now baby is now not improving because has gone again on the ventilator. So CT scan, even ultrasound will also give some more diagnosis. CT chest is required and bronchoalveolar lavage or ET secretions are also.
Yeah, but you are saying ultrasound. Now baby is on ventilator, off ventilator, plus minus. Ultrasound will tell you that areas of consolidation, collapses, effusion, but will not help me where the problem is, isn't it?
Yeah.
Isn't it?
But
so in that case, if Sunil, if I ask for the PCR, that is a fashion right now, that nasopharyngeal PCR, bronchial lavage PCR, send the whole panel costing something 15,000, 70,000 rupees, and whether that will help this baby or not.
Sir, PCR will definitely help because then we are looking for an organism specific and the sensitivity is more and specificity is almost 100% of a PCR test. So definitely it will happen in this case. And I think if the panel done, which is around 35,000, patient is affording, we can definitely go and do.
But if patient is not affording,
Then if the blood culture is negative, because blood culture has a sensitivity of only 14-15. And
anyway,
PCR
a little short of the time.
Yeah.
Quickly, I was asked of the panelists, what is your opinion of PCR-based diagnosis? ET secretions for the PCR. The panel is coming up, viral panel, pneumo panel.
Frankly, we are in learning phase. So we are exploring them. Wherever we get stuck, we try to use them.
Okay.
Somewhere they are useful, somewhere they are not. So collecting a ball in a 1 month old child is also not an easy task, particularly a child who is having distress. It will be a really tricky thing. So that thing is really difficult. We do BAL through the tubes on venti, but there the childs are little bigger with the ET tubes of more than 4.5 size. Otherwise, it is not
So
possible.
for this baby, that was not possible.
It is really
Ravi,
difficult.
your chance
Sir,
on this?
in this age group, very early neonatal period, I don't think, and plus, good thing is our antibiotics are sensitive. So I have never come across how a PCR will be helpful in such cases. But we got recently one baby who went home on oxygen, and then he came again with bronchitis. That adenovirus came out to be there. So later part after 1 month, it will
so
be
on,
helpful.
on day 2 or day 3 of life or day 2 weeks of the life. Manish, will you send or not?
No. Not
Okay, so let's continue with this case. Continue stay off and on support, and we could not extubate this baby fully. Mother is now very much visiting the baby. Again, X-ray taken, showed infiltratus consolidation. Now 4 weeks. Now it is showing collapse of one lung. And when it comes to collapse unexplained, obviously I asked my colleague to get scopy done. Bronchoscopy was done. And before bronchoscopy, this was the picture. This is a real picture. You can see the way baby is breathing, like he's trying to exhale with some obstruction. Can you see this? Now, because previously there was tube in, we could not take this kind of vision. Now it is very much obvious. And he's on nasal IMV with, I'll go through again. This is HFNC, but there is something happening here. Chest is also saying some some crepitations, saturating well, otherwise good size baby on full feeds, and we are on 35% effort with 18 on 8, 7.5 of PIP and PWP. Reasonably good pressures on this. Anyway, so based on this, because the obstruction, the bronchoscopy told us that there is something pressing the trachea. So thoracotomy was done, big, and the size of the lymph nodes were 3 to 4 centimeter. In this baby, which was obviously not seen on the X-ray at all, only collapses were seen. Histopathology shows granular inflammation, focal necrosis suggestive of tuberculosis. And then still I was not able to believe this. So what we did, we already asked for the BAL at that time because scopy was done. Bronchial lavage grew some gram-negative organism. I must appreciate, I will not name the laboratory person. I called him that the lymph node is showing this. We have done Zn stain or not? I must thank him. He said, sorry sir, we have not done, but we have reported is negative. Gram stain was suggestive, gram negative, but let me check with the Zn stain. So after looking at histopathology, I called the microbiology and asked him that Zn stain was done or not, which was not done but reported negative. So they started doing it and they're calling me that now few mycobacteria seen on Zn stain. And that's pus from this is gender, you can see, this is not 4 years, 4 months, positive for acid fast bacilli, 3rd August 2024. And then BAL, 10 days negative, 20 days negative, 58th day ABC positive for MTC on 58th day. The question with the allied family was that they are not able to accept, not accept, but that from where this bug came. Today also I don't know. If you look at congenital pneumonia, Ravi rightly can mention that how does the congenital will behave?
Tuberculosis generally will not present like this. It will go into liver. It's a hematogenous spread. So that's why little bit less likely to present. Yeah. But right from birth, it may be that two pathologies would have coexisted. There is a gram negative as well. But how such a sick child in congenital TB, very
Right
unlikely.
at birth with TB, it is.
Anyway, sir, the problem is that. So anyway, the problem is that as I told you, the teaching. Yes, sir, please. Yeah, please.
I'm sorry, I'm not a neonatologist, but let me tell you 2-3 things. If you get an unusual infection like in the newborn period with an unusual presentation, immunodeficiency should be on the card. Number 1. Number 2 is, suppose if this tuberculosis was not found, where we would have been. So I will try to get in at that point of time. If you have a stormy respiratory course in the neonatal period, please evaluate for cystic fibrosis. Please evaluate for primary ciliary dyskinesia, because those diseases will present later on, will make us smarter retrospectively in neonatology, but prospectively I can't tell you.
Sir, the moment we look at the collapses, we thought of it. And that 6 genes were already sent, but reports were awaited. Yeah.
surfactant deficiency, congenital. So,
Yeah.
Sir, even for immunodeficiency, you should also go for Mendelian susceptibility for mycobacterium
That is true. The
tuberculosis.
point is that baby is stuck on ventilator. I want to get baby off ventilator rather than jumping to the where the problem
No,
is. Absolutely.
Dr. Ashish,
Yeah.
I think even the immunodeficiency will also develop later on. But the first, how the child receive this organism. Because immunodeficiency person also, child also should receive this, should come in the contact, exposure. And for that reason, for congenital tuberculosis, 2 or 3 things we'll have to check. Number one, probably which we don't do.
I'll get 10 minutes extra because of the
But-
discussion, Chetan.
But no, but number one is the placenta, which we don't do, and second, even go for the endometrial biopsy of the mother. Without any manifestation, without any symptom, can it be even the tuberculosis to the mother, genital
Absolutely right. See,
tuberculosis?
as a clinician, we are stuck on this baby. We have got asked for the thoracoscopy, thoracotomy. We have asked for the CT angio. Two things are very important: the faith of parents in a clinician, not me or any one of us, and the way of counsel. And my first day diagnosis, but the counseling did help me. I said I don't know what is the problem. As far as management is concerned, I try to get baby off ventilator. The moment that's why I took the video. That this is what was happening. The moment we is taken off ventilator, because you are bypassing the obstruction on ventilator, you are all right. The moment take it tube off, baby is becoming in this kind of breathing. So anyway, so this was an interesting case. That's one. And then this is a follow up. Sir, it was done. Sir, it was done to tell you the truth. It is negative. Father, mother, caretaker, all were negative. I don't know where the problem was. This is that's why I put the reports and everything here. Yeah. You are right, sir, but radiology is mother. And I said that ultimately it comes to we start baby on anti-tuberculous drug. We advise that, sir. We advise to screen the family, screen the near people around. Okay. Anyway, the baby revealed osteotomy bronchus and baby improved and went home happily. Histopatho and CS fluid lymph nodes suggest tuberculosis was done. So for any pneumonia, ultimately what I want to bring here to the audience is that what is important is just stabilize the baby, give antibiotic, specific anti, and try to find out the bug. If not, then sit there and try to look at other, because Dr. Supreme already says cystic fibrosis and atypical pneumonias and all that. One need to think about it. That is the message that I want to convey. So we talk about the late pneumonias now. This was early pneumonia or congenital
just one
pneumonitis.
one
So the
more
diagnosis was initially was TTN, it was not getting better because of some bugs inside, which were not identified. The moment right bug was identified, we could treat that. That's the thing.
One retrospective observation.
Yeah.
Because the mothers could not conceive, that possibility
Might be possible. Might be possible. Yeah. Yeah. So that was the discussion with the obstetrician. Because here the obstetrician was also restless. What the problem is and why baby is still not getting better. So anyway, so that's fine. So now talking about the late pneumonias, and we know the most common bug would be the ventilator-associated pneumonias. And those who are working in NICU and PICUs, they would know how difficult it is once gets into this web kind of thing. So to treat that, or what would be the way to see that wave doesn't occur? So my August panel, I would like to take all of them to buy one by one. Hand hygiene, Dr. Ravi,
Yeah.
then Sunil and Manish and
Web bundles are the interventions together which will prevent ventilator-associated pneumonia. So everything clean. So right from when you intubate, your laryngoscope equipments, your hand washing will be there. Then suctioning tube as well. Every time new tube should be used, and your all equipment, ventilator should also be clean. So these are the other things. Then positioning of the baby, oral care as well, little bit of milking. So all those stuff together.
so Manish, what is immunotherapy? Oral care. There is some word like the
start-
buzzword,
start
immunotherapy,
early.
oral immunotherapy. What is that?
Yeah, start early at express breast milk,
Colostrum.
colostrum, like drop wise in the oral cavity.
Yeah. Apply few drops of the colostrum every 6 hours to the oral cavity. Just paint oral cavity with those things, and it's shown to decrease web. And it is a Cochrane-based Cochrane review is there on, and it is very helpful in preventing web.
Sir, we do
What
it
about
even
our
in-
humidifiers?
Even in intubated patients, we are giving oral
Yes,
immunotherapy because it is not getting aspirated. It will just coat the oral mucosa, which is a potent source of otherwise infection. So there you get the coating with mother's breast milk, colostrum, which will provide IG and several other things.
Absolutely.
And that is how it is helping.
Agar biggest concern about VAP is your humidifiers and the circuits. At least we have come to an age where we will start with the disposable circuit. All of us are using it, but the problem is the water into that. So Ravi, how will you take care of those things? Humidification, the water being used to humidify the lungs.
We use distilled water only. There is no other excuse for
Absolutely,
that, and it has to be changed every 24 hours as well.
Absolutely.
So that's very, very important.
Yep.
And same with incubators, what we are using, that also needs proper water as well as it needs to be changed.
Because the biggest source of
Sterile
infection
water, yes,
as far as
sterile.
vape is
It's
concerned.
sterile.
So quickly go to another case. Quickly, I understand we are running short of the time, but we'll quickly go through this. 30-year-old gravida to para one live baby, elective ASCS at 31 weeks of the pregnancy, severe PIH, incomplete enteral steroids, cried at birth, oxygen required was at birth, birth weight 780 grams, started on high flow, X-ray showing typical mild haziness bilaterally, query reticular pattern, and then for increased oxygen to 40% worsened distress on HFNC, intubated ventilated. So this is a case, clear-cut case. We are talking about a preemie, 31 weeker, 780 grams, obviously IUGR for that particular gestation age, incomplete steroids, having oxygen requirement, X-ray not helping me because may or may not be HMD, pneumonia, it can be anything. It's just showing haziness. So Manish, will you give surfactant or not? Because it is just 40%.
Yes, obviously, because we cannot differentiate at in this case like it is a pure HMD only or it, any pneumonia associated. So the preterm baby 31 week surfactant would definitely help.
So who will not give surfactant on this baby? Anyone in the audience? Pardon? What is that? No, madam, you know everything. Don't worry about that.
आवडતું ના તો મેડમ અમારી પાસે મોકલી દેવાનું
Okay.
સિમ્પલ.
So which
I say it's a time bound as well. So even if we are thinking other differential diagnosis, will give those things, but because we need to give it in and plus first 72 hours we will give surfactant on this. Plus incomplete steroids, such a low weight babies.
okay. So anyway, but concern on duty decided that we are just on 40% and the surfactant was not given. Okay, but that's fair enough that he can argue that all RDS will not require surfactant. You are 40%. Someone can that for small baby crossing 30% will require surfactant. Bigger baby is 40%. This was small baby, but somehow the consultant was courageous enough to sit tight on this baby and say that I have done ultrasound. Ultrasound is not suggestive HMD. A lines and B lines are all right. Anyway, so next day morning, that is 24 hours, almost 18 hours, we came on the round and we say that no, this is not acceptable. By that time, 80% oxygen requirement, surfactant was given. And by this time, obviously, the lung is collapsed, alveoli are collapsed, and obviously the X-ray is not going to be good and shows bilateral haziness. Now, because surfactant is late, the second dose is required. And then baby started improving. So those who gave that, और surfactant दे देना था उसका क्यों नहीं दिया? ठीक है नहीं दिया कोई बात नहीं. Okay, but with that also, the oxygen requirement came to just 40%. When Ravi does lot many ultrasounds and echoes and all that, and he says, what is PDA? So can this be because of PDA now?
It can be, but it is in initial phase, first 48 hours. So
Yeah.
PDA will cause more problem later after 3-4 days. But
Yeah.
first now we need to rule out, because even after 2 doses of surfactant, we are still sitting on 40%. So now again to think of sepsis or early onset sepsis also we need to think on that line. And then obviously PDA I will keep in back of mind, but I will not jump and treat at present on this.
So you said that sepsis was thought of, then CRP was positive, platelets are low, continue the same antibiotics. The question is that shall I continue the same antibiotic or also there's a different one? Yeah. Continue the same antibiotics or different antibiotics? Because we start with the penicillin and amikacin to start with, taking culture and stopping at 48 hours. Now CRP is positive, baby is improved a little bit to 40%, but then still not out of the woods because still stuck on the ventilator.
So that sepsis can also decrease can inhibit surfactant. So your baby has transiently improved after surfactant, but I'm not totally happy with the baby at present. So I will upgrade the antibiotics, taking blood culture.
Okay, Sunil, will you upgrade or not? Yes. Parag,
Yes, beyond 3 days we should, if there is no problem.
will you upgrade or not?
I will.
Manish? Okay. Okay. So anyway, what is the diagnosis then? We gave surfactant and we are talking about changing antibiotics. What is the diagnosis?
Why not both?
So,
Why not both?
fantastic, yeah.
Why
So
do you
at
need to
times
differentiate?
there is a baseline disease in form of HMDs, but at least I'll say 20-30% of the time we see that HMD was, yeah, the HMD was because of the infection itself. Pneumonia changes were not seen earlier. The surface can be because of the pneumonia, but you will get that feeling only after 40 in this given case. Preterm, small baby, incomplete steroids, elective CS. So obviously you're going to give surfactant, but when you're stuck on that and other things are ruled out, probably you're looking at the pneumonia associated sepsis, and that is what the case was. Last one quickly. Ex-preemie delivered at 26 weeks, birth weight 540 grams, treated for RDS, PDA, metabolic bone disease and anemia. Was discharged at 36 hours and discharge was 1.9 kg. Everyone is happy, clapping, then father, mother taking photos. Thank you, sir, that's fine. Here ultrasound normal and no ROP. So doctors done very good job that at 26 weeker, you are not seeing any ROP and ultrasound is normal and baby is going to reasonably good weight, 4 times of the birth weight is reasonably good. At corrected of 6 weeks coming to the OPD, the baby is not feeding well. An examination, there is a tachypneic, intercostal indrawing, LNRG flaring, air entry clear, no foreign sounds, admitted and treated for respiratory distress, started antibiotic after culture, CBC normal, chest X-ray showing patchy opacities. This is X-ray.
Could be anything. I mean, at this age, like any other infant, it could be any viral infection which would have led to this.
Absolutely.
If there
So
is any other
ultimately the
family
treatment
member.
remains same. You support the treatment and that is what we did. No improved antibiotics. CBC almost same. CRP becoming positive. Blood culture negative so far. And baby is not showing any other signs except distress. Which are the possibilities? 2D echo, okay. Yeah.
Post-term.
Okay. 6 with the corrected age, sir.
Corrected
So
age of
26 you
so
cut plus
now
6 weeks.
almost
Yeah, so
Screening
that-
was already.
Yeah, was discharged at almost corrected, then 6 weeks of the corrected age. So that tells me that there is something wrong.
Sir,
And
here viral panel will help in this baby because baby was at home and it's not like fulminant sepsis. It's not requiring hypotension is not there, but only respiratory distress. But and there will be like chronic lung now develop after going home.
now the last discussion was that if patient is not affording, don't set PCR.
This is after
Patient has all resources to pay the bill for those weeks. And now 25,000 rupees for that PCR, which we are not aware of, number one. And viral treatment is not possible. So will it be rational to send those PCRs and all that? Okay.
Can we wait
Anyway,
for
we asked for the urine PCR for CME showing more than 2 lakh copies. This was CME pneumonia, which was treated with IV gencyclovir.
but that also
discharged on
costs
oral after 2
2,000
weeks.
bucks. I mean,
Pardon?
that also costs 2,000 bucks minimum.
Yeah, but then 26 and 2000. This would have been proven much cheaper. See, I had history of anemia, baby required 2 transfusions. And we all know that the blood that we got is never CME screened. So based on that CRP positive, otherwise, ultimately what I thought is a non-bacterial sepsis. Maybe viral or anything else. So not fitting into NEC, but I know that baby received 2 blood transfusions. Why not to ask for the urine for PCR and become positive, treated with gencyclovir and went home. Thank you very much, friends. So quickly, age at disease onset and maternal history can provide clue about potential pathogens. Diagnosis based on combination of clinical, radiographic and laboratory finding. Only clinically, only radiography or laboratory diagnosis not possible in neonatal pneumonias. Microdiagnosis of different pneumonias, BAL versus ET aspirate, impossible. It's good to have it, but the usefulness of the BAL or PCR based diagnosis is more in the PICU, less in the NICU. That's what I can say before jumping to my laboratory colleagues. Congenital pneumonia is component of torch infections. Congenital never comes like that. And hand hygiene and web bundles are evidence-based approaches. Thank you very much.